So now stem cells, we're going to talk about what they are, what they're used for, where they come from, what we know already, and with the things that we don't know. There's a lot more we don't know than we do know. I guess you can say you don't know what you don't know. You've heard of embryonic stem cells, and that was obviously a controversy because they were using aborted fetuses to make stem cell research. And there was a big brouhaha about the fact that the federal government outlawed it. Well, let me tell you this, if you do stem cell research on embryos, the problem is going to be the compatibility, and that's something that they've known right along. So let's say you take and make an artificial heart because you can make it from an embryo, our bodies won't accept it. So that really is what led the way to adult stem cells. That's why embryonic stem cell research really isn't going on much in the whole world, because there's realization that if you do make an organ, you still got the compatibility issues. You've heard about people getting, say, a blood transfusion. They got to check and make sure the blood matches, and that's kind of simple. But to say give somebody a heart transplant, they got to be either extremely closely related like a twin, or otherwise they got to take anti-rejection drugs their whole life. There's these little leukocyte antigens on the outside your cells. And let's just say if you take 3 of them, just 3 of them, you'd have to go through 1 in 750,000 people to get somebody that's compatible just in 3, but there's actually hundreds. So I'm going to talk about what a stem cell is, what an adult stem cell is, this is what we're talking about. So now, when you were born, somehow an egg or an ovum got matched up with a sperm. Okay? And something happened, your mom and dad met and they maybe drank too much, or they were married and decided that they want to have babies. But something happened and these two met up. And when they did, out came a fertilized ovum. Okay, so a fertilized egg. And the fertilized egg, you could think of that's your first stem cell, right? Because that fertilized egg, and you can't see around the corner here, I'm just kind of doodling, there's not much going on. The fertilized egg is going to start dividing. It's a zygote, and it'll keep dividing and becoming a multicellular organism. And then eventually comes an embryo, which has got tons of little cells. Now, the embryonic stem cell research came about from using aborted embryos from abortions and taking those cells and thinking, you know, if this embryo can grow a whole human being, can it grow an eyeball or an ear or a heart? Well, they haven't really done that yet, but they've been starting to do that with growing, embryo tissues potentially into organs. We've got the whole compatibility issue. We've got the fact that it's illegal in the United States. There's still embryonic stem cells in the United States at universities, but they can't use them here. Anyways, the embryo turns into a fetus. And by the time it's a fetus, those embryonic stem cells are kind of gone. They've actually turned into something else. So a fetus is where now, instead of just like a little glob of cells that can turn into anything, it's already starting to develop elbows and bone and skin and a heart. In fact, about 6 weeks, you can see little activity of the heart with an ultrasound. So by that time, those stem cells have already differentiated into heart muscle, or leg muscle, or fat tissues, or skin, or brain, okay? And by the time the baby's born, now we no longer have embryonic stem cells at all. They're pretty much all turned into cells, okay? Now, where can you get stem cells from? Well, embryonic stem cell research, like I said, that's kind of pretty much right now on hold. I think a lot of people feel that we should be furthering that more, and I think they will in other countries. Maybe at some point we're growing organs and somehow can train them to turn into an organ that looks like yours, but that's probably 30 or 40 years off because there's this huge compatibility issue. Now, some people who are having babies, I know some of my employees that had children. We got about 100 women working here, so there's always somebody pregnant. And they're offered to bank their baby's umbilical stem cells because there's stem cells in your umbilical cord. There's not many of them, but the idea would be if your child needed stem cells later on, they could take those cells and grow them kind of like on a petri dish and get enough stem cells to use them like a drug. Now, that's not even able to be done yet, but people are banking them in the hopes that one day their kid needs them, they're there. Now, most of us, we kind of dodged that bullet. We're not getting our umbilical cords are long been thrown away, right? So, where else can you get stem cells from? Well, you pretty much have some kind of stem cell in every cell of your body. We might imagine that, we're born with the same skin we die with, but in reality, your cells are always turning over. Your heart cells are turning over. Your brain cells are turning over at a very slow rate. Your blood cells turn over at a very fast rate. your liver cells turn over. So you have these stem cells in your organs, but they're kind of hard to get to. So imagine in your skin, to get enough stem cells, say to use it for something, you have to take a big old hunk of skin off. We got a problem there, right? And that led to what is called bone marrow stem cells. So you have a bone, and there's bone marrow in there. Now the bone marrow is like the inside of the bone. So if you've had a T-bone steak, you can see a little bone marrow. The bone marrow is where your cells grow that make red blood cells and white blood cells and platelets, okay? So when you get, let's say you lost some blood or you had a blood donation, your body would just step up the efforts and make more red blood cells and white blood cells and platelets, and you'll drink water to get the juice, and you're back to where you are. So those are called hemopoietic stem cells, or blood turning the stem cells. But you also have something called a mesenchymal stem cell in your bone marrow, and that's the one we're going to be talking about, mesenchymal. So you have mesenchymal stem cells in your bone marrow. And those are the ones that can potentially turn into something else. Interestingly, the richest source of your stem cells might be there. We're talking about another area. But children have their third mandibular molar tooth is a rich supply of stem cells. And they're thinking down the road they'll be able to tap those and bank your kids' teeth when they fall out. Okay, and hang on to them. Okay, so we talked about mesenchymal stem cells. So here's how it works. You've got the fetus, a bunch of little cells, and that's very primitive. Okay, so that's like us being a monkey, like 10 million years ago. Very, very primitive. Then you've got mesenchymal stem cells, and then you have what's called precursor cells. So in your fat, you've got a pre-adipocyte or pre-fat cell. You might have a myocyte, which is a muscle cell, or a neurocyte, which is a nerve cell. That's a precursor cell. And then you have tissue. So the fetus stem cells can turn into any tissue. The mesenchymal stem cells can turn into most tissues, and the precursors can turn into tissues that are specific, like a skin cell, or a retina cell, or a heart cell, or like a bone cell or muscle cell. So if that's the case, what about using just bone marrow cells? Well, that's a good way. That's what the original research was done, was using your bone marrow. The problem is when you aspirate the bone marrow, they put a little hole in your hip. It's not really a terrible procedure, a little painful, it's tolerable. And they wash some bone marrow out, and you got such a small number of stem cells, they wouldn't do anything. So they would send them to a lab, and the lab would sort of bake them in a petri dish and make them grow. Okay? Problem right now is that the FDA won't allow it, because that's considered a drug. Okay, so if you take your tissue and have somebody grow it for you, it's considered a biologic drug, and the FDA wants evidence that it's going to be handled properly. You're not going to get germ contamination because it's going to be somewhere else. You're not going to mix up tissues. But right now there is active energy into trying to make it so that we can take your bone marrow, send it to a lab, and a drug gets sent back to you that's your own stuff. Okay, it'd be totally biocompatible, and you wouldn't react to it. But this is still, again, 10 years off. So that's a problem. So let's talk about the next thing. What is maybe a solution? And the bone marrow still remains a viable alternative, but it's not ready for prime time because, everybody heard about Gordie Howe. He had the stroke. They took his bone marrow, and he met them down in Tijuana to put his stuff back in, because they actually have labs that can make the stem cells here. They can't use them in the United States. Panama is a big state or big country for stem cells. You can do it in Canada. All right. So what about other tissues? Well, we talked about the fact we can get them from your skin, but that would be a problem, right? Because you have to have scars all over you, and you still would have to culture them. You have them in your heart and stuff like that. But you certainly don't want to take your heart out and get stem cells out of that. But interestingly, your fat cells have a rich supply of stem cells. In fact, if you took, like I say, a teaspoon of fat and a teaspoon of bone marrow, the fat has 500 times more mesenchymal stem cells than the bone marrow. Okay? That might tell you that you don't need to grow them. Okay, so what happens? You've got your fat cells, and we always kind of thought that you were born with a bajillion fat cells and you'll die with a bajillion, and that's kind of true. So why do we need these little stem cells? Well, what happens about every 6 months to 6 years, a fat cell will kind of wither away and die. It ages. It's like it lives, like in dog years, you only have so many fat cell years. So a fat cell might live 6 months to 6 years, and for some reason the ones closer to your skin die faster, so you have more stem cells there. And when they die, they send out little messages called cytokines to these stem cells to turn into a pre-adipocyte, to turn into a new fat cell. Okay? So your fat cells die, and a new one takes its place. That is one of God's meanest tricks, right? Right? So you have all the things you really, and I want to have my skin, my heart, and everything like that, but the fat cells, that maybe we could have bypassed. The fat cells that are closer to the skin seem to have a little bit more stem cells, and it looks like the stem cells are kind of attached to your blood vessels. So why do we have all these stem cells in our fat? Well, think about the organs in your body that really grow. Let's say during pregnancy you get really big, or you gain 300 pounds, and not just growing the fat cell, but if the fat cell grows, your blood vessels have to grow to accommodate more nutrition to the big fat cells. And that's probably why there's so many there, because that allows us to get big and small as we want to. And we have enough stem cells to turn our fat cells over for hundreds of years. Okay, so how is this done? I come in the office, and we numb you up, take the fat out of anywhere. They've shown that it pretty much doesn't matter where they come from. You have about the same amount of stem cells anywhere. Maybe closer to your skin you have more, so we do liposuction superficially. We numb you up, you don't need to be knocked out for it or take anything for it, and then we take the fat out with a little liposuction cannula. It's not done with any machines, just like a little syringe attached to a device. And then we go through a process where the fat comes out kind of clumpy a little bit, and we put an enzyme in it and breaks it up, and then we find that the stem cells are heavier than fat cells, so they fall. Okay? It's like you had water on the bottom and oil on top. That's because oil is lighter than water, or gas is lighter than water. So the stem cells fall, and we go through a process of washing the enzyme back out, and then it's deployed. So how are they deployed? Well, one of the low-hanging fruits, or the really easy to test areas, is arthritis, osteoarthritis. You look at people with, say, arthritis of their knee, and they're thinking, well, I don't want to get a knee replacement because they're only good for 10 or 20 or 30 years, and clock's ticking. They might be looking for something else. So STEP became a popular area to look at stem cells. So if you look at your knee, and then you have this is your tibia and your femur, over time, kind of get this loss of cartilage, and you lose your joint space, and the knee starts hurting, and it starts moving less. And that occurred from years of damage. Maybe genetically you're predisposed to the way you work. You might have a little bit of knocked knees, and you're putting stress on them. Well, what if we put stem cells right into the knee joint? Right? Because it'll be clear that they're not going somewhere else. We put them in say, applied it on your skin. So they did a study with 1,200 people, and they did 1,800 joints. Some people had more than one knee treated, or knee and hip treated, and they were knees and hips. And these were candidates for total joint replacement. These were people that had knees that they wanted to be replaced. And at 2 years, only 2% of them got the surgery. It means 98% of them thought it worked enough. So most people got more than 50% pain relief. And they've also done studies showing that this tissue does thicken. It never goes back to a normal knee. Okay? But no matter how bad it is, it still seemed to work. Somebody that's really heavy, they'd get a slow response at the same rate as somebody that's thin. Obviously, somebody heavy, there's a concern regarding them continuing to wear the knee out, so we'd want them to lose weight so that they don't need it again so soon. Does it last forever? No. I mean, something happened to give you arthritis in the first place. Those conditions are still there. I'm going to give you a list. I just kind of looked in some of my journals that I've been reading over the past few years. But these are some areas where they studied the mesenchymal stem cells. Insulin, that's worked successfully, got successful response. Insulin-dependent diabetes, nephropathy from diabetes, cerebral palsy, which is obviously more for children, multiple sclerosis, pulmonary fibrosis, COPD, emphysema, retinopathy, macular degeneration, retinitis pigmentosa, interstitial cystitis, progressive supranuclear palsy, neuromyelitis optica, joint disease, osteoarthritis, rheumatoid arthritis, ALS, which is Lou Gehrig's disease, wounds and skin flaps, heart failure, spinal cord injuries, Parkinson's disease, Huntington's chorea, Alzheimer's disease, hip necrosis, limb necrosis. So the spinal cord injury is what got my attention because my brother had a spinal cord tumor. He was at St. Vincent's Hospital in Indianapolis a few years ago, and they more or less left him for dead. They said they couldn't take it out. So we took him up to Cleveland Clinic. Found a doctor that would take the tumor out. It was invested into his spinal cord, and he got it out. But he went from being paralyzed and not able to breathe, almost dying, to really can't walk that good. He walks with a walker, but he gets around, so he survived. Back to work. And he said, I want to ride a bike again. I'm like, this ain't going to happen. It's just reality. So I started researching stem cells for spinal cord injury. There's actually been numerous studies published, first in rats, where they break their backs and treat them, and then in vets, people in the army. And they've shown that the closer you get the stem cells to the time of injury, the more likely they'll have a recovery, in some cases a full recovery. My brother was out about 4 years. So we did 2 stem cell deployments. He went from a walker to walking without any assistance, but he's not riding a bike. Okay? So I'm going to keep treating him until he can. I think one day he can. The stem cells, we've used them for different conditions. How long does it take to work? How you know it's going to work? What are the side effects? Let's talk about that. How long is it going to take to work? Well, for like arthritis or knee pain, it's anywhere from about 2 weeks to get some anti-inflammatory response to 6 months. So most people respond in that time frame. For neurologic diseases, same thing. Some people respond right away, and some people respond months later. And why is that? Well, there's 2 components to the stem cells. In reality, when we're injecting what we call stem cells, that's a misnomer. We're actually injecting something called stromal vascular fractions. And it's a fancy term for, well, stem cells and some other stuff. And the other stuff is anti-inflammatory, things that modulate your immune system. So in addition to stem cells, there's these little things called T cells and B cells and endothelial progenitor cells, cytokines. And what they found is that when you inject the stem cells, the first thing to do is they modulate or alter immune problems. So somebody that has, say, lupus or MS or Crohn's disease, or ulcerative colitis, rheumatoid arthritis, Sjögren's syndrome, scleroderma, these are all where your immune system is attacking your body. So you're supposed to have your immune system protecting your body, but when it attacks your body, that's an immune system disorder. And when we inject the stem cells, the first thing they do is they sense where that inflammation is going on. So you put it in, through an IV, let's say, and stem cells just become part of your blood supply. And how do they know where to go? Well, if you think about it, you're breathing oxygen, and your tissues that require oxygen, they suck the oxygen out of the hemoglobin, right? Well, in the case of inflammation, the cells that are inflamed are giving off little chemical messengers called cytokines and other messengers. And they're saying, I'm being attacked by my own body, help me. Okay? And they attach themselves there, and they apply immunomodulating efforts, and it seems to turn off that kind of inflammation. Something that I've been interested in is MS, because my grandmother and my aunt died of it. And this is before we even knew about stem cells. This is a autoimmune disorder that we had pretty much unknown causes. And the patients that were treated with stem cells in every clinical trial showed benefit, but the lesions in her brain didn't go away. So in this case, we know that the stem cells can turn into neurons, but probably they're mostly working on just by attaching there and not really growing new brain tissue, but just altering the immune environment for sufficient time for people to get better. And it's probably not going to last forever. It's going to last probably for a year. The second part is they attach and they grow. So we know in the knee, we inject them in the knee because it's easy to get in there, and they've shown that you can actually increase your joint space a little bit, and they can grow a little bit of cartilage. Okay, so they can grow some tissues back. People with hip disorders, where their hip is kind of eroded away, they're growing back bone. Okay, in other places where there's, say, an autoimmune condition, it's altering your immune system, allowing things to grow. So basically, we're going from, say, replacing hips, taking drugs to suppress your immune system, to regenerating things. That's why people might call this regenerative medicine. You're using your own cells, positive properties. Your stupid fat cells have this ability to grow themselves forever. You can live without them, right? And most of us say, I don't really need all these fat cells. You lose a few, it's fine. Even somebody that's very thin and emaciated, because they were sick, we can get enough fat cells out. When we do the procedure, we take out about 50 to 100 cc's, which is like, say 10 teaspoons or 20 teaspoons. And then we process it and get stem cells. If we do 50 to 100 cc's of fat, we get about 50 to 100 million stem cells, and then we deploy them. They did experiments where they were trying to figure out, how do we know these are going to the target organ? And they would tag the stem cells with a low-grade radiation, kind of like they do in a nuclear medicine test, like a stress test or a lung scan. And they had a guy that, for example, he had Dupuytren's contracture of a finger, where the finger had inflammation causing it to hook up, and his penis was crooked, which is called Peyronie's disease. Apparently that's what President Clinton had, okay, according to Monica Lewinsky. Anyways, they gave him his stem cells IV, and they wound up in his penis and in his hand. The original studies, because it's been very interesting for neurology, because many of these neurologic conditions such as ALS, Parkinson's, multiple sclerosis, NMO, have no treatment. Okay, no treatment that really works, let's say. They work a little bit, but not much. They would deploy them actually into the spinal cord because you know they get in there. Well, then they did some research with using a medicine called mannitol, which is like it's something we use in trauma when somebody's got brain swelling. And it basically drops the pressure of the brain a little bit and lets the stuff get through the blood-brain barrier. So they've taken people and injected them directly into the spinal cord with stem cells and then done an IV with the mannitol, and it works just as well. So you don't even need to have a spinal tap done. So it's pretty much just done through the IV or into the joint or tissue. How about safety? Well, you know, the FDA is going to want 20-year data before a drug is approved, at least 10-year data. We don't really know right now. One postulation could be, can they cause cancer or can they stimulate cancers that are growing? Well, interestingly, they've used it to treat people that have cancer, and they were able to follow these people along so they had no acceleration of cancer. They've done enough patients with stem cells to say right now there's no evidence that they can cause cancer. People with cancer can be treated, but that is definitely a caution. I would be uncomfortable with somebody with a history of cancer and treating them with stem cells. We don't really know about that. But there is no evidence that they would cause cancer. What about other conditions that can be triggered by stem cell therapy? There are no known adverse events. Okay? So the reality is there's no known complications. It's not like we have 100 patients or 1,000 patients or 10,000 patients. There's tens of thousands of patients have had this done, either from the bone marrow or from the fat. So at this point, I'm just going to stop for a minute and introduce Dr. Kehoe. Want to come on up here? Do you have the hand mic? Dr. Kehoe is an orthopedic specialist. I've known him for years. He evaluates, one of the common things we see is joint problems. So he evaluates them for joints, and let him talk about his experience with it.
And we've known for a long time orthopedics and stem cells have a lot of benefit. And a lot of stuff that we use in our trauma surgery, we have products we buy commercially from companies that have human tissue in them, and those companies will advertise their levels of what are called MSCs, which is the mesenchymal stem cells, for using in broken bones that need to be stimulated to heal. So we already are onto this kind of bandwagon for utilizing human tissue and particularly stem cells for healing. And along those lines, anybody in here who's had an orthopedic condition and has seen a surgeon for joint problems, there's a variety of things we've been doing over the last 10 to 15 years. We started with, everybody knows about a steroid shot in the joint, which really is no treatment at all. It's an anti-inflammatory, it provides temporary relief, and when used repetitively, can actually damage cartilage. So then we were using viscosupplementation, some people call it chicken juice, chicken fat. Its chemical name is hyaluronic acid, hyaluronate, sodium hyaluronate. There's a few other names in the chemical formulas. Original brands were made from rooster cone, and that's a substance that is present in our knee normally, but then goes away when we have arthritis, which leads to a higher level of inflammation and friction in the joint. So it came out of Japan originally, and the thought was we'll inject this in the knee in a high volume, it will help people. And it does, there is some benefit to doing it, but it's a temporary fix. And the typical length of relief is anywhere from as little as 3 to 4 months to as long as 6 to 12 months. But it's just another type of a patch. And there are some insurance carriers in some other states that are starting to not pay for the hyaluronic acid injections because the benefit is such a short duration. Then we moved on to platelet-rich plasma, and you may see that out there being used. There are some orthopedic surgeons that market stem cell therapy, and the platelet-rich plasma, we draw blood out, about 60 cc's of blood, and we centrifuge it to separate the platelet-rich component of blood from the non-platelet component of blood, and then we can inject that into a joint. The problem with that is there are stem cells in our circulating blood, but it's very, very small numbers. They're those stem cells that have been activated from our bone marrow for use somewhere else. So it's not like we have a flood of them in our blood. So there's very, very few blood stem cells in a platelet-rich plasma, and that's really kind of a misnomer for people in my profession to market that as stem cell therapy. So when we look at stem cells, when Dr. Mok talked to me, well, let's look at fat and bone marrow both, and what is the benefit of each? And when I started looking at the literature that was out there, what I could really find was that the biggest difference is adipose-derived or the fat-derived stem cells have much better anti-inflammatory properties and much greater numbers per cc of tissue. Bone marrow stem cells don't appear to have any advantage. The potential advantage of bone marrow stem cells is if you're in Germany or Czechoslovakia and somebody can aspirate just a little bit of bone marrow, 10 cc's maybe, and then those can be grown in a lab up to the big numbers. It could be a minor procedure. Unfortunately, in the U.S., we don't have that available today. So the companies and the surgeons that are out there that are doing bone marrow stem cells, they're doing a bone marrow harvest, which is much more painful than having liposuction done. And they're aspirating anywhere from 60 to 180 cc's of bone marrow and then concentrating that. And the amount of stem cells they get are minuscule compared to what's derived from fat. So when the patients have come to see me that question me about this, their question is, well, why am I not doing it in my office if I'm an orthopedic surgeon and that's what I do? And there's a few reasons for that. The big one is you don't want me doing your liposuction. That would not work out very well. So you want me to do your knee replacement, that's great, or your rotator cuff repair, but you don't want me doing your liposuction. So the doctors that do liposuction tend to migrate towards the fat-derived stem cells. The other group of doctors you'll see are pain management doctors or physiatrists. They have live x-ray machines in their office where they can look at images live and they can do bone marrow harvesting. So those two groups kind of are the ones that specialize in it. And most of them partner with orthopedic surgeons and some other specialists for some of the other diseases to do that aspect of it and those evaluations. When we look at the orthopedic patient, Dr. Mok described, it's not, your joint's never going to be like it was before. If you've got bone and bone arthritis, you're going to have, the hope is you're going to have pain relief. You're maybe going to have a little bit of the joint space come back, and you're going to hopefully have pain relief. But the conditions that led to arthritis are not going to be changed by this. And if we could solve that problem, Owen and I would retire somewhere. But we're not going to fix necessarily the problem that led to that osteoarthritis. Now we look at things like rheumatoid arthritis, autoimmune type diseases. Stem cells become very intriguing because what role do they have in things that are truly genetic? But when we go back to osteoarthritis, the patients that come to see me, there's a couple of key things I look for. If somebody has a deformity where a joint is bent 45 degrees and it doesn't bend, we're not going to be able to fix that with stem cell therapy. We can't correct deformity with it. But a joint that is that has mild deformity, is inflamed, has x-ray findings of arthritis, those patients are the patients that really are going to probably do the best. And maybe the ideal patient is the patient who doesn't even know they need it or wants it. And that might be the 17-year-old high school soccer player who tears their ACL and we surgically reconstruct the ACL. That joint may benefit from stem cells. And in them, it may actually prevent them from having arthritis in 20 or 30 years. The unfortunate thing about those patients is once they recover from their surgeries, they don't have pain and they don't seek out any additional treatment. But with regards to osteoarthritis, most of what's being done is in the knee and then to a lesser degree the hip and the shoulder and the ankle. And that's because the knee is a very easy joint to inject. We can put large volumes of fluid in the knee. In the hip, we're limited with how much fluid we can actually put in the hip because it's a very tight joint. The shoulder is a little bit harder joint to inject. But as we've had advancements with ultrasound technology, we've gotten better and better at injecting some of the more complex joints. So we can expand this to that. I think it's very exciting. It's the naysayers in my field about it, I think, are because of, well, why is a cosmetic guy or a pain management doctor doing stem cell therapy? And my response to those same doctors in my field is, well, why are you doing platelet-rich plasma in your office when we know it doesn't do anything at all? Because there's a lot of people still offering that, and it's easy to do. It takes 10 minutes to draw the blood and 15 minutes to centrifuge, and we can inject it right back. But there's really not any benefit for osteoarthritis with platelet-rich plasma.
Tore my rotator cuff, got worse and worse, and I was supposed to have a surgery to replace it by Dr. Kehoe referred me to. They're going to open it up, shorten a tendon, and repair it. And platelet-rich plasma has been shown, Tiger Woods had it done for one of his tendons. It's been shown to help with inflammation and partial tears. So we had our ultrasound tech go out and learn how to do ultrasound on the shoulder. I bought the machine to make platelet-rich plasma, and we injected it, and the damn thing grew back like 100%. I never had the surgery.
Yeah, that was a pretty interesting thing, because
Yeah.
he called and said, I don't really want surgery, I don't have time to do this, we inject my shoulder. And the platelet-rich plasma for tendon healing, some of our wound healing, we use it on incisions, it can be beneficial.
Right, so PR platelet plasma works. We use it for hair growth, for tendons, but it does not help with arthritis, doesn't help with conditions.